Awesome. Hello, everyone. We'll just wait 1 minute for folks to come on in and get settled. Thank you so much for joining us today. We are excited to have you, and we'll just give it 1 to 2 minutes. If you would like, feel free to say hello in the chat. Let us know where you're tuning in from. Welcome, welcome as folks are coming in. Feel free to say hello in the chat and where you are tuning in from. Just going to give it a minute for folks to come on in. All right, we've got a few more folks in here. Welcome, everyone. Thank you so much for joining us today at our very first Launching Inclusive Cancer Care, the LGBTQ SOGI Data Initiative Kickoff webinar. We're really excited to have you all here today. This is the first webinar of a 4-part series working to assist with deepening the understanding of health equity, data advocacy, and the power of inclusive health systems. We're super excited to be starting off with so many amazing individuals in the room. If you'd like to introduce yourself, go on ahead and do so in the chat. My name is Aston Williams. I use she, they pronouns, and I am one of the program coordinators for the California LGBTQ Health and Human Services Network, and I'll be your host for today's session. I'll be joined by a few of my colleagues and awesome partners that we have. We have some folks from Southern California HIMSS joining us, our amazing evaluator, Shannon, excuse me, Shannon. Like I can't speak today.
Kozlovich, like I'm from Chicago.
Thank you. That will be assisting us with the main content of today's session. So we're super excited to have you all here. I'll go on ahead and start with Zoom etiquette. We do have a Q&A session for the last 15 minutes of our webinar. This is, again, a webinar series, so we cannot see you. So if you are multitasking or biting on some lunch, that's totally fine. You can communicate with us via chat. If you have any questions, there is a Q&A section, so you can pop your questions in there. You can pop them in there throughout what we are sharing with you all today, and we'll get to them at the very end. If we happen to not get to your questions, don't worry about it. We will have our emails up if you want to ask us personally, and we'll try to answer any questions with a follow-up email as well. So thank you so much again for joining us, and I will jump into our agenda and what we'll be covering today. So today we'll start just with a few acknowledgements, just an overview of the California LGBTQ Health and Human Services Network. And then I'll pass it over to Mary Beth to talk a little bit more about the Southern California HIMSS chapter. We'll go over the foundations of the LBTQ Health Equity Initiative and what we're doing, our program offerings. We'll talk, I'll pass it over to Shannon to talk a little bit more about SOGI data and its importance, and Midori will also jump in as well on this great information. And then we'll pass it over to my colleague Lou to talk a little bit more about how to get involved. And then we'll end with our Q&A. So it'll be a great time together, and we hope you all get a lot out of what we're sharing with you. We'll go ahead and start with a few acknowledgements. I'd like to start with just taking a moment to acknowledge the land that we are currently on. I am actually located in Sacramento, which is the occupied territory of the Nisenan, Miwok, and Patowin people. And I just like to acknowledge the folks who make up the land and the original stewards of this land. We'd also like to recognize the Tomba and Chumash people that have been located in Los Angeles, and we'd like to also acknowledge them. And we also recognize and pay respects to the past, present, and future generations of Native and Indigenous people, and express our gratitude for the stewardship of these lands. Additionally, we want to share our solidarity with those who have been affected. We know that there's a lot going on in California, specifically surrounding the fires that are happening in Los Angeles and the surrounding areas. We know that a lot of people have been touched by this. A lot of folks have family members. Some of you are tuning in from the LA area, and we're truly grateful for your presence here today with us. Amidst all that's going on, we hope that families and folks are safe, and we're truly honored to share this space and time with you during your lunchtime, as all this is happening. So without further ado, I'd like to jump into our content. I'll go on ahead and pass it over to our manager of programs for the California LGBTQ Health and Human Services Network, Isaias Guzman, that will talk a little bit more about what we're doing currently at the network. Isaias, I'll pass it over to you.
Sure, yeah. Hi, everyone. My name is Isaias Guzman. My pronouns are he, him, and his, and I'm the manager of programs at the network. The network is an LGBTQ specific program of Health Access, who's our parent organization. We bring together over 60 nonprofit providers, community centers, researchers, stakeholders, and more to advocate collectively for state level policies and resources to advance LGBTQ health and LGBTQ health equity. We advocate for policies. We expand coverage and improve access to quality healthcare. We work to strengthen programs and build capacity for member organizations and increase funding to LGBTQ health and human services organizations. Some of our programs right now are focused on tobacco control equity and promoting. Oh, there it is. So some of our programs include tobacco control under We Breathe and Out Against Big Tobacco. Through our We Breathe program, we support funded tobacco control projects in eliminating tobacco use by 2035 by providing expertise on LGBTQ communities, reducing tobacco use, and addressing related health disparities. And through Out Against Big Tobacco, we focus more locally in the Los Angeles area to pass tobacco control policies and address health inequities in California's LGBTQ plus community. And last but not least, the LBTQ Health Equity Initiative, which is what we are going to be discussing today. So I'll let the rest of the team talk more about those.
Thank you so much, Isaias. Appreciate that. So these are our faces. If you haven't been able to see all of us, these are the folks that are assisting with this work with the LGBTQ Health Equity Initiative. So we have myself, Isaias. We have Ari, who is behind the scenes today working as our tech person. We have Lou, our network organizer. They'll be talking more about our communications work. Danny is our network director and does a great job at leading us with all of this work. And then we have the wonderful Shannon, who is our evaluator and also the founder and CEO of Just Causes, LLC. And Shannon will be sharing a bit more about what she does and the amazing work. So that's our little team. I will pass it over, I believe, to Mary Beth to talk a little bit more about HIMSS, the Southern California chapter. So Mary Beth, I'll pass it over to you.
Thank you so much. Welcome, everybody, and thank you for joining today's SoCal HIMSS co-sponsored webinar. Our chapter is dedicated to advocating for healthcare innovation and equity by fostering education, collaboration, and transformative leadership across the healthcare ecosystem. I would say go on to the next slide. Thank you. So I'm not going to read every slide to you today, but I wanted everybody to understand a little bit about who HIMSS is, particularly our Southern California chapter. Today's topic exemplifies our mission to support meaningful dialogue and innovative solutions that address healthcare disparities by focusing on inclusive practices and the power of accurate and representative data We aim to equip healthcare leaders and providers with the tools to deliver equitable and compassionate care to all populations. Next slide, please. Just a little bit about HIMSS as an organization. There are over 55 chapters nationwide. Our Southern California chapter is one of 2 in the state of California. And as an organization, we hold in excess of 350 events, over 750 education hours. And I have to believe that this number in reference to volunteer leaders has drastically grown, because we have got a number of people who are supporting our chapter, as well as the HIMSS organization nationwide. Next slide, please. HIMSS provides training and education, as we said in the beginning, for all of our membership. And so just like to include a little bit of leadership training and some of the benefits. If those of you who work in healthcare technology and healthcare, or just technology, are interested in learning more, please take a look and see if there's something that sparks your interest. Next slide, please. I think that we have the majority of our executive board for this year that's present on this call. Thank you for supporting the educational focus of this event, as well as continuing to support the chapter. Those folks that are on the call, please take a moment to introduce yourselves. But I know I saw Carrie Murray, Armando Chacon, and of course, Midori Kondo is going to be one of your speakers today. Next slide. It takes a village. And particularly now in the Southern California area. So we've got a number of committees. Certainly those of you who are interested in learning more about our chapter, we'd love to have you participate. Here's a general overview of the folks who chair our committees. Feel free to reach out if there's an area that sparks your interest. We'd love to have you join us as well. Sorry, next slide. And then here is a quick snapshot, which we can certainly share with you later, of a number of programs that are coming up over the next several months. So we'll include this after this event is over. Next slide, please.
Awesome. Thank you so much, Mary Beth. We appreciate that overview of the work that y'all are doing.
Thank you.
Wonderful. Yeah. So we can jump into the foundations of the LBTQ initiative. So what are we doing? The new lesbian, bisexual, transgender, and queer health equity initiative was launched by the California Department of Public Health, CDPH, to address significant health disparities affecting 2.5 million Californians who identify as LBTQ. This program aims to tackle several critical issues, including systematic anti-LGBTQ bias, the lack of culturally responsive care, and the shortage of medical services and research tailored to the LGBTQ community. In particular, this initiative is focusing on the needs of LGBTQ women, transgender men, non-binary, and gender non-conforming individuals, ensuring that their unique health concerns are addressed and prioritized. A lot of times when we're doing LGBTQ work, there's a lot of funding that goes specifically to gay community or certain communities that don't include these individuals. So we wanted to make sure that this work is hitting on those specific individuals. Another important goal of the program is to build the capacity of service providers to deliver care that's culturally and linguistically responsive to the diverse needs of the LGBTQ community. This initiative is working to develop and implement community-led training and technical assistance for healthcare providers. So we want to empower you all to have the tools and the knowledge that you need to provide effective and affirming care. We want to strengthen the continuum of care for LGBTQ Californians and ensure that all folks across the state have access to services and the support that they need. So under CDPH, this is a 2-year initiative that is set to conclude in March of 2026. A few of the goals and objectives, just so it's clear, we have a goal to increase the number of cancer care clinics in Southern California who include sexual orientation and gender identity, SOGI, data in patient medical records. So there's 3 objectives that we are attempting to hit for this program. Number 1, to increase the number of health data management system staff and stakeholders who intend to have the ability to include SOGI data within their health data systems. And doing this through online training tools and educational materials that we can provide. Increase the number of cancer care clinics in the Southern California region who intend to implement SOGI data collection in their medical records by providing training and technical assistance for you all. And then also our small goal is maintaining our statewide advisory committee. We have an advisory committee full of great experts in the field that are assisting us with the designing and implementing activities that support survey development, all of that great stuff specifically for LBTQ population. So we've been meeting with them, getting all of their feedback and implementing it. And so we've definitely reached that goal, and it's helping us create all the things for this program. So a few of the offerings and services that we have from this program is actually this webinar series. So the Let's Be Equity quarterly webinar series is a space where we will be meeting. Folks can come and gain insights from patients, providers, and experts in the field and learn how to improve care. Today we have Shannon talking a lot about just the basics around this, and we'll continue expanding. So definitely stay in touch with us to come back for these webinars and get more information. We'll also have educational materials. We currently have some educational materials that we'll be talking about in just a few minutes that we've already created, but we will continue creating educational materials and would love your input. And so we'll talk about how to get involved just in a few. Like I was saying before, we have our SOGI and LGBTQ plus trainings. So we do want to make sure that folks feel competent on these different topics. We know that this can be new for folks, and so we want to make sure that you all feel comfortable if you do want to implement this type of training in your clinics. And then we also provide on-site training, so in-person trainings, specifically for cancer care clinics or clinics that may want to implement this work. And then we also offer ongoing support. So we do want to assist with some technical assistance to ensure that work is inclusive and equitable. So if y'all are like, we love this, we want to get involved, we probably should have someone else look over it, we can definitely do that for you. So these are just a few things that we're offering from these programs, and we hope that you all joining us today are interested in getting involved. Great. I will pass this over to Lou, I believe, to talk a little bit more about our strategic communication.
Yeah, hello everyone. I hope y'all are having a good lunch, and maybe eating behind the camera. But yeah, I just wanted to go into some of the things that already Aston has touched on, such as like our goal. Our goal is to create educational resources and tools to support SOGI data implementation, empowering health data professionals, and to provide inclusive care for all. We want to essentially create these resources for you so that you can bring them into your own work and create spaces where everyone is included. And this can be in the form of fact sheets, it could be in the form of videos, social media toolkits, it could be anything and everything under the sun. Anything that will help you create the amazing work that y'all are doing already. And we do want to share some of the most recent education materials we have already created. So our first one is the project landing page, which I'll go ahead and also share in the chat so y'all can see what I'm talking about. But it essentially goes into like the about us, getting into why LBTQ, and also sharing information about like, some things like the webinar that's happening here today, and giving you the opportunity to see where you can get involved in the work that we're doing. In addition to seeing other resources that other folks are creating within this work and our own educational materials we're also creating, which leads into our next accomplishment in our educational materials, which is an LBTQ Health Equity Initiative one-pager. This is very similar to the landing page, with the exception that it is much more cohesive. It's much more just on one page. So like if you want to share this with like folks digitally or printed, it's all there. You can take a quick glance and see what our main goals are, our key activities, and just like the possible outcomes that can come from this. Um, and then, what those are some of the things that we have created. And with that, we do want to create, a total of 3 to 5 educational materials. And that will kind of go into a little bit more of what I'll get into later. I'll go ahead and stop there, but I'll go ahead and pass it on over to Shannon.
Amazing. Thank you.
Stop sharing so then you can share, Shannon.
So thank you so much, Lou and Aston, for setting up just exactly what this initiative is about and what it is that we're doing here. So to kick us off and get us started, I am Dr. Shannon Kozlovich, she, her, hers pronouns. That's doctor as in scientist, which definitely means we're going to be defining terms throughout this entire presentation. So don't worry, there will be lots of definitions. Also, feel free to submit questions throughout the presentation. I will definitely address the ones we have time for during Q&A. I also have the chat open, so just in case there's anything that I feel like I want to talk about or address while I'm going through each of those slides, I can absolutely jump in and do that. I will be joined later in the presentation by Midori. Midori and I have done collaborations together for many years, and I'm going to go ahead and ask Midori to introduce herself really quick so that y'all know who you'll be hearing from later.
Hi, thank you, Shannon. It's been a pleasure working with you and all of our colleagues here on this topic. It's such an important topic, and so thank you for including me. I'm Midori Kondo, and I am the Chief Application Officer for Fred Hutch Cancer Center, as well as I serve on the board for Southern California HIMSS, and thank you for our HIMSS board for being here today, and Mary Beth as our leader and president for this year. It's been a great experience, and thank you for supporting this effort. Just wanted to turn this back over to you, Shannon, and let's jump right on in.
Great, I love it. So for anyone who's wondering what it is that I'm doing here, because I don't work for the network, I do run a small business called Just Causes, where we really believe that data equity is health equity. And so we do a lot of grant writing, grant evaluation, and just general support and assistance for nonprofits, particularly LGBT nonprofits or any social justice nonprofits that are out to save the world. We are doing a lot of the research, data collection, and data analysis so you can take that data and save the world. Now, as promised, we are going to get directly into defining terms. And we've talked a lot about LGBT and SOGI, and there's going to be a lot of acronyms. Our community loves an acronym, let me just tell you. So we're going to go ahead and go over SOGI plus data really quick. We have SOGI, the SO is for sexual orientation, and that's defined as the identity that one holds based on physical, romantic, and sexual attraction or lack thereof. Some terms for sexual orientation are straight. So yes, if you're straight, you do have a sexual orientation. There's also terms like gay, queer, demisexual, and so much more. We could be here for 3 years if we wanted to list them all. We also have the GI in SOGI Plus data that stands for gender identity or gender, which is defined as one's innermost concept of self as a man, a woman, a blend of both, or neither. This is how individuals perceive themselves and what they call themselves. Some terms for gender are woman, boy, two-spirit, genderqueer, and again, so much more. We create language and to define our identities. And so the language tends to be extremely vast based on each individual's experience. And then we have the plus in SOGI data, which really includes sexual characteristics and more. And so this is where we talk about the biological, physical combinations of internal and external sex organs, as well as hormonal environments. Sexual characteristics includes our societal definitions of sex and includes intersex folks who don't have that so-called typical combination of sexual characteristics. Although there really isn't a typical set of sexual characteristics, but that is definitely a tangent for a different time. I was only given 20 minutes. So really, our discussions here today are primarily focused around why this is important health information to collect, and also why this is important health information to disclose if you are an LGBTQ plus person and you live in an area that you feel comfortable disclosing this information in a health data setting. As a data nerd myself, the simple reason to collect SOGI data is to have a complete data set. So we can account for variables or identify outliers and really figure out what it is that's impacting the health data that we're looking at and health outcomes. But when it comes down to SOGI data as health data, this actually impacts the treatment that we receive in a clinical office. When I go into a doctor's office, I'm so often asked if I'm sexually active. Yes. Then asked what birth control I'm using. None. And really, after only those two questions, I shouldn't be required to take a pregnancy test before imaging, nor should I be given that annoying information packet about geriatric pregnancies and the dangers of those. I get it. I'm not at an age y'all want me to get pregnant, but my girlfriend can't get me pregnant. And I feel extremely unseen when those things happen to me over and over and over again in clinical offices. And we all feel unseen by these kinds of microaggressions that we face in society and in our medical office when we go see doctors. SOGI data in healthcare spaces can help to mitigate these occurrences in doctors' offices where we need to feel safe to be willing to access care, because data equity is health equity. And the language that we use matters. Collecting data is important. So is being able to talk about it. Language matters, and language shapes society. Which brings us to the acronym, because I'm sure you have all seen. You saw LBTQ at the beginning of this presentation with the specific initiative put out by the California Department of Public Health, which is focused on creating equity and providing funding to LGBTQ plus community members that are not usually having a lot of funding go directly to them. But then there's also LGBT, LGBTQ, 2S LGBTQ plus, LGBTQIA, 2S plus, and all of the varieties of the acronyms that are there. No matter what acronym it is that you are using, the LGBTQ plus is an umbrella term. It is a term or an acronym that is used to cover a lot of different sexual orientations as well as genders. And the acronym that you choose to use in your organization, or the words that you choose to use to identify yourself, those are based on how you identify and also based on the services that your organization is providing. If you do not provide direct or special services for intersex communities, you probably should not have the I in your acronym. It becomes misleading. And please, when you include LGBT of any sort in your acronym, make sure the T isn't silent. Make sure that transgender folks are held within your areas of service and are part of what you do every day. There are now two acronyms that are out there for queer communities, and they're really not equal. Sexual and gender minorities, or SGM, is a term that's placed on our community by outside agencies, particularly funding agencies and science agencies that were looking for an all-encompassing term to use for the types of projects that they wanted to fund. LGBTQ plus or minus a few letters is the acronym that LGBTQ plus communities sees themselves in. SGM, if I can make my slides work properly, or not. Let's do this. Don't use the SGM term or acronym in any community-facing reports, publications, or health education materials. Personally, I recommend only using it when it's required by a funding or reporting agency and not allowing it to appear anywhere, even in internal communications or documents, to build up the habit of using affirming language within your organization and within the work that you do. So when we talk about language, sex and gender are two terms that have their own separate terminology already built into the English language. Sex is a medical or societal designation placed on people at birth based on the appearance of external genitalia or their chromosomes. In humans, this are various combinations of X and Y. And the terms for sex are male, female, and non-binary, depending on the area that you live in or the documents that you're looking at for any particular area. I will say biologically, sex is not binary nor sexual characteristics. Like I said before, that's a soapbox for a different time. So gender, on the other hand, has a very separate set of terms and terminology and language within our society and within English as a language structure. Gender is a person's innermost concept of self as a man, woman, both, neither, somewhere in between. And the terms for gender have greater variety than our terms for sex, because these are terms that each of us individually find and use and reach or create to define how it is that we are experiencing our own being. These are terms like woman or girl, man or boy, non-binary, genderqueer, gender fluid, two-spirit, etc., on and on. And what we need to do is believe people when they tell us who they are. And when we're looking at health data collection specifically, when your only options within your health clinic or the data that you're working for use sex terms on gender questions, you can actually correct this error when you're drafting your reports or data summaries and correct gender terms to proper gender terminology. This correction within your own analysis will establish and secure the difference between sex and gender and how each of these demographics impacts health or health services differently, because they do impact health and health services differently. Another piece of language is adjectives. They're very fun. Yes, I'm a scientist. I also read a lot. I really like language and defining terms. Some of you might have noticed that the term transgender wasn't included as an example of a gender term. This is because transgender and cisgender are adjectives that we use to describe gender as either aligning with sex or not aligning with sex. Transgender is not a gender in it of itself. Rather, it's a descriptor added to a person's gender. When transgender is a descriptive option, cisgender should also be available as a description option. This way, your forms or reports are normalizing this language and creating equity within your work. Transgender women are women, transgender men are men. When your gender options appear as man and trans man, it sounds like you are saying man and fake man. Instead, you can offer cisgender woman and transgender woman as options to expand equity through the language that you use within your workspaces and daily lives, frankly, because we can all just use a little more adjectives in our language. They definitely color things up and describe things delightfully. This does bring us to the topic of pronouns. We all have them. Pronouns are identifiers and descriptors within our language when we are referring to a person or a group of people. They're used in everyday speech, and this is everyday speech that changes and adapts over time. After all, there was a big upset in the 1800s when folks started using the pronoun you to refer to a singular person rather than a group of people. Did you know that the pronoun you was originally a plural term and never to be considered a singular term? Otherwise, it wasn't grammatically correct. There you have it, folks. Language is ever evolving. You can absolutely ask someone about their pronouns if you're unsure. While this does not obligate someone to answer you, it's far more respectful than using the wrong ones. You would ask for someone's name when you met them if you didn't remember it or you hadn't been introduced to them yet. It's pretty much the same thing. When you get it wrong, and you will, correct yourself and move on. No one should be subject to over-the-top reasons for the mistake or excessive apologies. Mistakes happen. We can't all be perfect all the time. And when you over-apologize or make a bigger issue of something than it is, you are putting a lot of pressure and emotional effort, or asking for a lot more emotional effort from the person you are talking to, even if it was your mistake that was made. And so just correct and move on, and think about it a little bit more next time. Now, we're going to pivot a little bit into drivers of human health and well-being. I do use the term drivers of health rather than determinants of health because I really just absolutely love language. And a driver feels like it can be changed, while a determinant feels more finite. And as a career and also just being raised an activist, I will say that I really like a thing I can change. Two of the largest drivers of health are our political and social environments. When I say political drivers of health, I'm not only talking about politics and laws. This also refers to the policies that are held within institutions. For instance, policies that govern the collection, use, and language of SOGI data is an example of a political driver of health. While the language that we choose to use to discuss SOGI data or LGBTQ+ communities is a social driver of health. We may have been taught as kids that sticks and stones will break our bones, but words will never hurt me. But that was all a lie. Words hurt, and how you choose to use language shapes our social system and the social system around you, including your workplace. LGBTQ+ people have become the scapegoats within our political system over the past 4 years. Since 2020 and every year after that, we've had record-breaking years for anti-LGBT legislation to be introduced within our state and national governments. And California was not immune to this. When I talk about the impact of language to create equity, this is the backdrop of that conversation. This is what our communities see and hear about on a daily basis. When it feels like a big hurdle, when it feels like a lot to ask and a difficult data set to work with to just implement SOGI data collection, keep in mind that there are people behind these numbers. People who are actively being legislated back into the closet, people who have to hear and listen to legislation that is introduced, even if only a small subset of this legislation is being passed. We still have to hear about it every day from friends and family, on the news, on social media. This is definitely the backdrop conversation and our baseline of where we start as queer folks in society right now. And 2025 does not look to be any different. This legislation adds to already high levels of minority stress faced by LGBTQ+ communities. We are a part of every other marginalized community. So the microaggressions, discrimination, and oppression that we face based on our sexual orientation and gender gets compounded for folks who also face racism and other forms of discrimination and oppression from intersectional identities. Minority stress is a concept or a term that is used to define mental and emotional strain that marginalized groups experience. And this really is due to society and how folks are treated. When we talk about social drivers of health, we are talking about those social and cultural factors that add minority stress into people's lives. We are talking about the things that folks face that make it more difficult to access care, that make it more difficult to hold and maintain a job, that make it more difficult to find a comfortable place to live where you can feel safe and secure and affirmed. Minority stress can come from internalized stigma that we have been raised to feel about our communities, thus about ourselves. It can be from social stressors that we face from people outside of the voices that we live with in our own bodies, and also discrimination, direct or indirect, microaggression or overt. It is all discrimination and oppression. And to give an example of the impact that systemic discrimination and oppression can have, if we look over the cancer continuum, which really brings us back to why is the LBTQ initiative through the network focusing on cancer care? And it's because we have seen the impact of discrimination and oppression across the cancer care continuum for LGBTQ plus people, where we're impacted for cancer prevention because we have increased risk factors related to minority stress, such as increased substance use. We drink more and smoke more tobacco than our straight cisgender peers. We also have a higher rate of background just stress that we live with on a daily basis. This then leads into cancer detection. We have a built medical mistrust because of the microaggressions that we face within our healthcare system. It makes it so that we don't go to the doctor at the earliest sign of anything. We are less likely to go and get our screenings to detect anything early because of this medical mistrust that's built up, which then also means that our diagnosis comes later and later stages, and can also lead to questions about treatment, the research gaps that we have, the gender-based and heteronormative clinical guidelines that exist out there, and really a lack of tailored resources and low social support. And that then bleeds into survivorship, where we might have a lower rate of survivorship or harder time accessing end-of-life care. Or we don't have a lot of support groups that we can go to talk about our diagnosis or the diagnosis of family members and the impact that that's had on our lives. So that was a lot of very heavy information. We went over terms and terminology, how language creates equity, the impact that just society and discrimination and oppression have on our bodies and our beings and who we are and how we access medical care. So right now, before we get into talking about how the issues within data collection, I just want everyone to take a quiet moment, take a deep breath, have your body relax, because there is still more that we'll be talking about. And there will be a part where we ask you to step in and to start supporting and how you can help and start being the solution to a lot of these problems. So right now, deep breath in, hold, deep breath out. Thank you all so much for making it this far. Data collection, it isn't easy. A lot of it isn't easy because LGBTQ plus communities might be a smaller portion of the general population, although not as small of a portion of the general population as people think. LGBTQ plus folks make up 10% of the population of California. We make up nearly 8% of the population nationwide. 42% of us fall within racial and ethnic minorities, and 25% of Gen Z adults are identifying as LGBTQ plus. So if you do not have the numbers that you need now in your SOGI data collection modules, in your EMRs, you will as soon as our young folks start needing more care or have access to healthcare. But again, topic for a different time. Among our trans communities, 58% of LGBTQ plus youth identify as transgender and non-binary, with 71% of them reporting gender-based discrimination, particularly in healthcare settings. So when we talk about data and small data sizes, I mean, many of you are already collecting this data. Our EHRs have actually done a great job creating a standard SOGI data module that can be turned on. So if your clinic isn't already collecting it and you have an EHR, check, do they have a standard SOGI data module? If the answer is yes, turn it on. I know it's not that easy. Midori works in this field. She'll tell you why it's not that easy, but it is important. And so working towards turning those data sets on is one of the things that really needs to happen. And then we hear a lot of, but compliance is low. Not very many people are filling out these data sets. And I'm here to tell you that we still need LGBTQ plus folks included in your data reports. Call it descriptive data. Say that there's not enough data for further analysis, and include the results or the data that you do have. Small data sets matter. And in order for us to be seen, we're going to have you publish and put out reports that include these small data sets as your team works to improve compliance for these data measures. So now you've all heard me talk quite a bit, and I'm going to go ahead and pass the floor over to Midori for the next couple of slides.
Thank you, Shannon. So it is a complex network of different systems that we have in our healthcare organization. And so I thought I would walk through a little bit as we tee up the small data sets and the importance of really understanding this ecosystem, particularly this, this is part of our partnership with Southern California HIMSS is providing some awareness around how this ecosystem really impacts the cancer data set, but also the SOGI categories as well. So we're getting into now smaller data sets. So out of the SOGI population, those SOGI folks that have, or our minority folks that have a cancer diagnosis, we're talking about even smaller data sets, right? So it's really important to understand this ecosystem. So it is required for us to report cancer cases, and these are new cases as well as there's a full data set that also includes mortality data to our state registries. And so in order to do this, how we need to navigate this full patient record and really make sure that the continuity of the data that's captured is really happening all the way from the start of when it's collected in the EMRs all the way out to the cancer reporting. So I'm going to just go through this a little bit, and for the sake of time, I'm going to be sort of moving through quickly. So we've got hospital systems, physician offices reporting out these cases. They're seeing these patients. They're collecting this information in the EMR. Hopefully, they're looking at their demographic information and their SOGI categories, and addressing and helping their cancer patients be seen with having the right language. And so this information is then abstracted out by our cancer registrars. So our cancer registrars actually have to go into these EMRs and look for this data set that needs to be reported. In addition to that, there's ancillary systems where they're having to capture a lot of information from pathology and, where's the tumor site, and looking at laboratory data and looking at all these different ancillary systems that they're also collecting information on. And then they're taking this full data set, and more commonly, there is a specialty system that supports these certified tumor registrars. That's what a CTR is. And this is our cancer registry staff that actually have credentials and training to be able to actually even put in staging for the physician, as well as partner with the physician on what those staging cases are, because their data quality has to be really, really sharp in order to do the cancer reporting that's both at the state level and the national level. So these folks go in and they're looking at these different systems to be able to abstract out. It's usually manual, and then they're coding it and putting it into the special CTR system, which then is reported out to the CDC, which is in the NPCR, or the National Program of Cancer Registry Surveillance System. And most states are actually supported by CDC. There's about 46 states, the District of Columbia, Puerto Rico, a few other sort of island areas that actually use the CDC Cancer Registry Surveillance System. And then there is a subset of folks that also use SEER, which is a surveillance epidemiological and end result program. And between the two of those programs, 97% of the US population comes together. And then when you add in the District of Columbia, that completes the set that gets reported nationally. And that goes into a full database for the US cancer statistics. So you can just imagine the data quality and the information that's captured way up front from the EMRs, including the demographic information, really impacts how this reporting happens to this national data set. And then in that national data set is when the work really happens around research and looking to see what programs get funded for underserved populations and for where our cancer burden is on evaluating how our programs are doing around lung cancer. So Shannon mentioned smoking, really wanting to do some screening on these patients, looking at their risk for cancer and getting up front and trying to reduce the burden of cancer. All of that comes from this national data set. So it's really important for folks to understand, particularly that work in the health information technology world, on how this all comes together and how you can start to become an advocate and support us getting to a complete data set. Next slide. So what can you do about it? You can advocate for change, help get better data sets in the EMRs, help support that reporting and being as accurate as possible. There's a number of programs our folks have been talking about on how they can help you have the right language, capture the information with the SOGI categories to look at our populations that really are not being addressed with their cancer burden, and really helping to have screening and preventative programs. So it's really important for you to understand how this comes together, and even look in your technology today to see how well you are actually capturing this information, and how you can attend for further trainings to really understand how to better capture this information. Let the patients feel safe to be able to report this out so that you can capture this information in your demographics and report it out accurately. Without this information, we cannot figure out exactly where to put our resources to prevent cancer. And particularly, it happens to our folks that are at the intersection of having SOGI data categories, and as well as being in other areas where you have minority populations, Hispanic populations, people of color. All of those folks really need to have an accurate data set for us to be able to do that. And these folks here, our folks on this call here, provide these programs to help you understand. So really look out for these trainings, ask questions, figure out how you can have a better data set, develop your understanding of these invisible communities, and get comfortable with using this language. And it becomes very important to how we address and really help these folks survive and strive in their lives. So I'm going to pass it over to now you, Shannon.
Yes. Well, Midori, thank you so much for that mic drop right there. That is exactly what it is that we need to be doing and what we are doing here. So up in the corner of this slide, you will see a QR code for those of you who are sitting here and you have already finished your lunch. Go ahead and get a jump start on the evaluation survey we're going to ask you to do at the end of this. Tell us what you've learned, and then tell us how you want to get involved. Make sure that You add in your name and email address at the end. It will not be attached to your answers to the evaluation survey because we're keeping that anonymous, but that is how the network can get in contact with you for however it is that you would like to be involved, or if you are interested in signing up to hear about the trainings. So thank you so much for sharing space with us here today and for just sitting in so many of the problems and hearing about the first steps to making a difference and saving the world. I will go ahead and hand it over to Lou for a little more about how you can get involved.
Yeah, thank you, Shannon. That was really insightful. And I know that was a lot of information. So I definitely don't want to give y'all even more in your head. So I'll be pretty quick about this one. But yeah, some ways to get involved. We do conduct consumer testing specifically with our educational materials. And the best way to help you help us is for you to give us feedback on how we can improve the educational materials we are creating for you all. You are also more than welcome to join our listserv. Through there, you're able to get, updates on events and opportunities to get involved in the implementation of SOGI data. And then really quickly, I'm very excited to announce that we will be having an event. It is called Data Dreams and Schemes and Creative Schemes, generating ideas for inclusive ed materials. It is essentially a brainstorming session held on February 21st from 2 to 3:15 p.m. It'll be a space where we can get together and create very inclusive materials for both the communities and for you all as healthcare providers, and figuring out ways on how we can best make the tools for you. There's only a handful of us in the communications department, and we definitely don't want to speak on behalf of all of you. And we know that you all have very invaluable insights that could help us create these educational materials and resources for the improvement of your work that you're doing. I will go ahead and drop the registration link for there, and I'm so excited to see you attend. I want to make it very fun. In a time where fun is resistance, and getting together and kind of creating very creative play through our work is the most important thing right now. So I will leave it there. But yeah, thank you.
Wonderful. Shannon and Midori, thank you so much for sharing all of your insights. All of that was such valuable information. Y'all are such dynamic speakers. I was definitely keyed in on everything that was being said. So thank you so much for sharing your insights. Lou, thank you so much for sharing how to get involved. I think also just for this data dreams and creative schemes, it's also important to know, if this is new to you, please join us because we want to know where the gaps in knowledge are. So if you're like, I really want to know more, and this is all new to me, and this is something that I think could be helpful for me and my team, we want to know that information too. So all folks are invited to come in. If you know some folks that may not be here today, but may be great to join, please send this information over to them as well, or take a screenshot, and we'll be happy to see you then. Yes, so we've come to the end of our webinar today. Just wanted to throw up our contact information. Feel free to take a screenshot. We are all open, emails are open for any questions you may have. We are getting to the Q&A portion of our time together. So thank you for hanging in with us. We really appreciate you all coming during your lunchtime today. I'm going to throw back up the feedback form for you all. Again, Shannon was talking about this earlier. Please go on ahead and if you are on a computer, go on ahead and scan this QR code to provide some feedback. All your feedback is always very helpful. And I think we may be able to drop it in the chat again as well for folks that may be on their phones or other digital devices for today.
And like we already talked about, data is equity. So the more data you give us, the better we can use it to keep funding, to keep doing these kinds of events.
Yes, thank you, Shannon. Yes, right. We just talked about data's importance, so assist us. Wonderful. I think we are moving on to our Q&A portion. I believe, Ari, you can tell us if we have any questions. If folks do have questions, I believe there is a Q&A section, but Ari, I'll let you explain that. I don't want to give
Yeah.
the presentation.
Yeah, definitely. So for folks on Zoom, you should see like next to the captions or like those little icons, you should see a Q&A and a question mark box if folks want to leave questions there. We currently don't have any, but folks, don't be shy, or you can also raise your hand and we can unmute you if you'd rather vocally ask your question as well.
So while we're waiting for questions to come in, there was a comment put in the chat about the way that data impacts funding. And Aston, I know that you mentioned it, and so did Midori, and Mary Beth, I know you're familiar with that. So I thought maybe we could just start by talking about just how imperative this is for the funding that we get to be able to do the work as well. Does anybody want to kick us off with how data impacts funding and the money that nonprofits use to do all of their amazing work? Midori, did you add?
I was actually going to just mention that, and so I focused in on a piece of cancer care, but as an example, the data sets, and this is just sort of grants that are provided for research or to provide for cancer care. It's really difficult without having a good data set to really show where there is gaps in healthcare and help and support, to make sure that even folks that really understand. So I feel like maybe I feel biased, but Lou, Aston, Ari, Asias, what you guys do to help all of us understand a lot more around the language that's important for our patients is really critically important. And we don't even have that even in some of our grants built in nationally, unless healthcare organizations take the monies that they receive and want to help fund these programs. And so, starting just sort of at the macro level, Shannon, just to sort of talk a little bit about that, we focus on, how we get grants to do research, but we don't often write in or think about others that are needed, other stakeholders that are needed to be successful. So I did want to just sort of call that out, that, I would ask my colleagues to really take a look at that and see how they can actually incorporate others and particularly these important programs in the community to help make research enrollment and support with the funds that you have right in to help support different groups, that we have to make us successful. How about that, Shannon?
Yeah, I mean, I think it's perfect. I can't tell you the number of times I've gotten feedback on research grants saying you didn't submit enough data to support the research that you want to do. And I'm like, well, I submitted all the queer data that exists. So I'm sorry, there's not enough data out there for me to be able to generate more data. Like, I don't know what you want me to do. Maybe fund the research so that the data exists for the next person.
Yeah. I will also add in too that I think happens a lot within communities that we have a lot of qualitative data, like a lot of us share our experiences of what's happening. But the quantitative data is also a lot of what's needed for like policy work and different things like that. Folks want to see the numbers and all of those things. And so like I think someone had said in the chat, I think it was Bill, talking about being left out of data collection also means being left out of the funding. When we don't have those numbers and grants are asking for those numbers, it makes it really difficult. So just backing that Within community, we share our stories, we share a lot of what's going on, but sometimes it's the numbers that, well, majority of the time, it's the numbers that are really wanted. And so this information and this data is so important for our communities, and it's so important for folks to be asking. Yeah, I believe Ari may have said we're starting to get a few questions in.
Yeah, so the first question we have from someone is, are there any SOGI data question templates that people can use? And I've also left it in the chat if it's helpful to read the question as well.
Yeah, so in terms of templates, it really depends on where it is that you're trying to collect this information. For community-based surveys and research, the California Health Interview Survey, or CHIS, has done a lot of field testing of SOGI data question and answer sets. While they do use sex terms for their gender and question answers, that tends to be one of the only changes that I make to that data set or that question and answer set when I am asked for just my opinion on what kind of SOGI data collection should be used for community-based surveys. And in terms of health data collection and standards, I will say that CMS, or the Centers for Medicaid and Medicare, have a set of SOGI data that they use. And then the Interoperability Office has a set of SOGI data question and answer sets that they use. Do you think that they match? As a matter of fact, they do not match. And then the National Cancer Institute, that funds a majority of our cancer research in the United States, also has a set of SOGI data questions. And do they match either the interoperability standards or CMS's data set? No, they don't. I think one of the biggest challenges is that we don't have a standard stable template that is able to be used across a lot of different organizations, which means that all of our small data sets, it's hard to go out and do what's called a meta-analysis, where you go look at all the data that's been published and then add it together, because we're not asking SOGI data in the same way across all of our studies that are put out there, or all of our data sets that are put out there. It's harder for us to add them together to make larger data sets. I don't know if that was helpful at all, but I mean, so templates exist. There's a lot of places. The Trevor Project has a great set of, this is how we analyzed and ask questions to youth when we're doing community-based surveys. The Fenway Institute and the Williams Institute have some templates for SOGI data questions and some suggestions for those for research projects. The University of California, San Diego's Transgender Advisory Committee for their HIV/AIDS department, research department, came up with a fantastic decision tree for research scientists in when to include SOGI data and what types of SOGI data questions to include based on how you're designing and developing that research.
Shannon, super helpful, and I think helps address that first question. The next question we have is, how do we find which EMRs, or electronic medical records, have SOGI data captured, and are they all the same?
So I can answer some of that, Shannon. We have most of the larger, and I say larger, EMRs, example, Epic, Cerner. There's the larger EMRs that do have some templates in there already. That's in the demographic section of the EMR. There is a standard data set that comes out from Epic as an example. You can make some modifications to the category list, and that's available. There's not a really good, there's not like a resource that you can Google to put it in there to find out if all the other minor systems out there, particularly there were some struggles with the FQHCs on a lot of their light EMRs. And what I mean by that is there's some EMRs that are actually funded to support FHQCs and folks that can afford the price tag of a larger EMR. And you'll have to work with your vendors on whether they've got the data set or not. That's where there is sort of not a standard across all the EMRs. Now, I will say what's coming is the standard for doing reporting. And as the CDC is developing the cloud-based platform for reporting and having interoperability be considered, there is a lot more effort being focused on around EMRs being able to have a standard data set, which would include that in all the EMRs for their reporting purposes. And so that is coming. There's a lot of work that's happening to modernize the CDC platforms, as well as to establish standards for interoperability. So stay tuned. There's going to be more standards coming, but for right now, you're still going to have to ask those questions.
Awesome. Thanks, Midori, for providing more context there. The next question is, does the recent 2024 regulatory requirements around capturing, monitoring health equity data inherently include collection of SOGI data? Anyone wants to know?
Yeah. Does anyone from the network know how to answer this based on the bill that was in California that was requiring SOGI data collection for public health funding? Didn't that get passed?
There's
not to call all y'all out, but
Hi, y'all. This is Danny Sesenia. I'm the director of the network. Yes, so we actually just passed a bill last year, SB 957, that is going to require the Department of Public Health, as well as all of the county health departments and their subcontracts to collect SOGI data. However, the bill does not go into full effect until 2029. However, CDPH can implement it sooner than 2029 to all of the different county health departments and all of their subcontractors and such. So it's slowly being put into the process. Additionally, the Department of Healthcare Access and Information actually just today is having a webinar on all of their data sets that's now available on their website, where you can ask for specific data sets in regards to prescriptions and hospital stays and readmission and things like that. And they have been incorporating SOGI data collection in that realm as well. So all of the various state departments are slowly incorporating it, and there is legislation behind a lot of these things. But this is where this project is very important, because all of these state departments want a standardized way to collect SOGI data and not collect it in different ways. That way they can cross-reference the different data they're collecting. And by the various departments being on this very important advisory committee and working with Aston and Shannon and Midori and everyone else on this team, we will be able to standardize that, and everyone will be able to take it back to their departments, implement it, provide educational materials, all these things. So all of the work is very much interconnected, and I'm really excited and very proud of Aston, for leading this work in this initiative and working so closely with Midori and Shannon, and for Midori and Shannon to really input so much time into this, for that standardization as we're working with these various departments. So I hope that answers that question.
Yeah, and then just to piggyback off of what Danny was talking about, thank you so much, Danny, for hopping in. I know that might not necessarily have been in the plans. I just voluntold people to answer things. But so this project will also be launching a LGBT community-based survey on affirming language within SOGI data collection question and answer sets, as well as definitions that are used within electronic medical record systems or health data systems to define terms like sex or sexual orientation or gender. And so if you are someone who is interested in, if you identify as LGBTQ+, you're interested in providing feedback for that survey, or you would like to be able to distribute the survey and help us find folks to answer it, go ahead and fill out that feedback survey. As soon as you tell us what you have learned today, it will take you to a page that will ask you if you want to be included in the network's listserv. Go ahead and say yes. The survey will be launched out to the listserv, and you'll be able to find other ways to get involved and help us have a very robust data set for that, so that we can really start providing the information on how LGBTQ+ communities in California feel affirmed when they are asked SOGI data questions in health settings.
Oh, Midori, were you gonna add anything there?
Oh, I was actually just going to mention that along the same lines that Danny was talking about, the grant programs for national funding. So with FQs and with and I know Shannon put in there, thank you, Shannon, for putting in the acronym, because we like them in healthcare too. That you'll start to see mandates that are following the same timeline that Danny was talking about, right? So as some of the legislation goes in, you'll start to see the vendors sort of snap into line in order to meet those regulatory standards. So thank you, Danny, very much for bringing that up.
Thanks all. Moving on to this next question. What are best practices to protect LGBTQ+ folks' identities when collecting data, considering the upcoming administration? You know, in similar ways, the immigrant communities are at risk, you know, when asking for immigration status. Any guidance there from y'all?
So I will say that when I design and develop opinion surveys or any kind of evaluation surveys that are asking people to disclose anything about their demographics. So if I'm asking about age, race, sexual orientation, gender, whether or not folks are trans, and any questions like that, I do that only when the answers are anonymous. And so a lot of this goes into, do you have to collect identifiable information for individuals, or do you have things that can be de-identified? And in terms of healthcare settings, we have an entire Health Data Privacy Act that is regulated by HIPAA. And so your health data should not be disclosed outside of your healthcare environments.
Just
And that's,
oh,
sorry, go ahead,
yeah.
Midori.
I was just going to add on to that, just a point of clarification too. The data sets that are submitted nationally are anonymized. So when our registrars validate that we don't have duplicates in those analytic cases, once it's submitted nationally, there's no identifying information. So just to sort of clarify and support that, that your identities are protected. And so it's really at the sort of the N of one, it's important for healthcare organizations to remember their HIPAA responsibilities and make sure that when they are engaging with the LGBTQ+ community, that they're also being sensitive with the questions that they're asking, collecting the information, and not showing, outward bias, and really addressing that as a culture in the healthcare organization to make sure that people feel safe to report it, because that's where your information is tied, and then it's anonymized. So it's really up to us, right, to really also protect those patients that are coming in that need our support as healthcare providers, and then making sure that their information is safe when it's shared out.
And just looking at the landscape of the incoming administration and the federal protections that may not be additionally being put in place or may be rolled back, like Midori said, any state-based data or local data that's collected from your healthcare institutions in California, it's not attached to you as a person when that data gets submitted to these federal databases that are collecting nationwide data. In addition to that, the state of California has protections, and we recognize that there are not the same kind of legal protections in every state. So when we look at whether or not it's safe to disclose identities in Texas when you are going to a doctor's office based on whether or not you can be denied care for what it is that you say or who you are in that office, that is a completely different conversation. And those are individual one-on-one conversations that you can have if you do reside or work in a state that has those pieces of legislation that have been passed and implemented, or have been passed and might be implemented soon. Reach out to Lambda Legal or any of your local LGBT organizations in those states that can help you figure out what the current political landscape is, because there are different political realities that protect your privacy and your access to care, and what discrimination is and is not legal. And so some of that puts the onus back on us as individuals to know what discrimination is and isn't legal. And that is disgusting and unacceptable, and we shouldn't have to be putting up with this. And we also recognize that this is something that is a reality, and a growing reality with the next administration that's coming in.
Yes, 100%. Thanks, Shannon, for providing more details there. Our final question here we have, and this is kind of a 2-in-1 question, and the first part might just need some clarification. They're asking why we're excluding trans women, but I believe we are not. That is definitely included in the project. And then the second part is if we are doing any longitudinal research.
Does anyone else want to tackle this first? I was like, I will always come off mute and talk. Like I will just say things to audiences. So
No, I was like, Shannon's unmuting. It's fine. Yes. Well, the first part, yes, we are not excluding trans women. We are including all trans individuals within this this work. So there's no exclusion happening. And for longitudinal research, Shannon, back me up on this one if you can, but I do know that this is for this project specifically, it is under CDPH. So we do have a limited time that we are working with this. But Shannon, please share, since you are an evaluator, if there's any longitudinal parts that I might be missing.
yeah, so in terms of the LBTQ study, some of the longitudinal data that we are collecting is we use the exact same evaluation survey at the end of every single one of our in-person trainings or our webinars. So we'll be able to track and see how well we're doing over time with the types of information that we're delivering. This is not a research grant so much as this is a project or a program grant. And so the difference there is a little bit nuanced, but also we're collecting data in order to improve human health and well-being for LGBTQ individuals in California. And what this means is we're going to be doing the best that we can to collect the data sets in the limited time that this grant gives us to collect them. Are we also going to go back and resurvey about affirming language over time to see how affirming language is changing? 100% we would love to. And we're funded based on what public health dollars or what grant funding is available at any given time. So if you are a funder or you have access to, you work on appropriations bills anywhere federally or in the state of California, please tell them that we need more funding for this type of community-based research and community-based data collection, because our opinions and our voices should be included in the legislation and the rollout of all of these initiatives moving forward, especially when it comes to mandating that data collection is happening. We want to also make sure that affirming data collection is happening, and that our affirming language is able to change and grow as society changes and grows over time.
Great. Thank you so much for that. Ari, is that all of our questions? I believe that one was the last one.
Yeah. Yeah, those were all we had.
All right. Well, that means I believe that we are at the end of our webinar. Thank you so much for all of you that decided to come join us today. Thank you to our speakers, to HIM Southern California, to the LGBTQ Health and Human Services Network, Shannon, of course, everyone who made this possible. Again, please fill out that survey and sign up to be part of our listserv so you can get more information of the webinars that are coming up very soon. We hope you have a wonderful rest of your week, and hopefully we'll see you again soon. Thank you.
Thank you, everybody.